Okay, today our topic is sepsis, and it's part of the February 2017 MEC Minute. I'm sure you're probably wondering, why are we talking about sepsis? We talked about it quite a bit as part of our protocol update for 2017, but I really want to touch upon it again because I think it's important that we all look at sepsis and understand how prevalent it is. We as EMS providers will touch, treat, and transport more septic or potentially septic patients than patients who are suffering from an acute MI, trauma, or stroke. About 28 to 50% of patients who arrive at the hospital and are hospitalized for sepsis will eventually die. If you compare that to patients who are brought to the emergency department and survive to admission who are victims of trauma or STEMI, they have a less than 5% chance of dying. And for us in EMS, sepsis has truly become the fourth time critical event. And it follows stroke, trauma, and STEMI. So when you see patients, part of what we have to do is have a high level of clinical suspicion for sepsis. And who are those patients who may be septic? Well, if you look at the four most common sources of sepsis, there are urinary tract infection. That could be in an older person who has altered mental status. It could be somebody who's got an indwelling catheter. It could be somebody who's recently had surgery on the urinary tract system, such as cystoscopy, or has had kidney stone extraction. Another common source of sepsis is pneumonia. Those are the patients who could have a cough, or they may not have a cough at all. In the elderly, the elderly may not have coughs as symptoms of pneumonia, but you have to think about pneumonia as a source of infection. Another common source of infection for sepsis patients is the gut. It could be an infection of the gallbladder. It could be an abscess within the abdominal cavity that's related to the appendix or diverticular disease, or they could have a perforation in the abdomen resulting in a walled-off abscess that causes sepsis. And the fourth most common cause of or source of infection for septic patients is the skin. So the skin is a great barrier. It keeps a lot of things out, but it also can be a source of infection. Think about it in the elderly who may have a decubitus ulcer, whether it's on the buttocks or on the heels or other areas because they're sedentary or bedridden. Think about it in patients who have uncomplicated cellulitis or what appears to be uncomplicated cellulitis but have a low-grade fever. They may also be septic. And also think about it in those patients who are IV drug users and may have an arm or leg abscess from needle sticks, or they could have a deep space infection of the muscles with fever and sepsis. So high suspicion in those four clinical conditions is really necessary. There are some other sources of sepsis, and you think about some of them may not be so common. I think all of us recognize that patients with meningococcal meningitis who have the big bruises all over their skin, with fever, they could have meningococcal infection and be septic. So think about that. Also, as a sidebar, if you see a patient like that, think about your personal exposure and use PPE. So mask, gloves, and eye shields. Sometimes people with ear or sinus infections could be septic. It's not very common, but it can happen. And then patients who recently had surgery may also be septic. So think about the patient who is 1 week post-op after having what may be a routine surgical procedure, but now they have a fever. They could have a surgical site infection, which could result in sepsis. Another thing to think about is which patients are at greatest risk for sepsis. So typically, patients at greatest risk are at the extremes of age. So infants, particularly those within 8 weeks of delivery, and the elderly. So any elderly patient is at higher risk for sepsis. Think about sepsis in the patients who are chronically ill. Diabetic patients and patients who have cancer are at high risk to develop sepsis, and those cancer patients can even be at greater risk for sepsis if they're currently receiving chemotherapy and have a depressed white cell count. They could be septic. Other patients who might be septic and who could be high risk are those that are immunocompromised, those patients with HIV disease or hepatitis B, hepatitis C, patients who have had transplants. They are on chronic immunosuppressants to prevent rejection of the graft. And then think about patients who are on chronic steroids, like some of our chronic lungers, or patients who are on other immunosuppressants such as Imuran or Humira that you commonly see now advertised for treating conditions such as psoriasis, arthritis, or inflammatory bowel disease. And the last group of patients to think at being high risk for sepsis are those patients who have had a previous splenectomy. They've had their spleen removed either because of trauma or cancer like Hodgkin's disease. And without a spleen, they're at much greater risk for certain types of infections such as pneumococcal infections and pneumococcal sepsis. So in the field, what do we need to do? Well, we have to maintain that high level of suspicion. Think that any patient with fever may be septic, any patient who's hypothermic may be septic, but also in a hypothermic patient, think that they may be hypoglycemic. So they could be a diabetic who is both septic and hypoglycemic, and they need insulin and treatment. Or I'm sorry, they need sugar or dextrose as well as fluids for sepsis. Think about any patient with altered mental status, particularly in the elderly. The elderly may not be able to develop a fever, or they may not have a cough that we would expect to see in a pneumonia, or they may not have symptoms of discomfort with urination when they have a UTI, even though they do. So any patient who's elderly and has an acute altered level consciousness, it keeps sepsis on your list of possible causes. And then again, anybody in the field that you see that may have a suppressed immune system, and think about those newer immunosuppressants that are being used for various skin problems or bowel problems, such as Humira. Septic patients may be sicker than they look, so you always have to have that high level of suspicion. I just want to mention post-sepsis syndrome. This is out there, patients who suffer sepsis but then survive. Patients can develop what's called a post-sepsis syndrome, and it could include amputations. I'm sure you've seen pictures of children in the who in the past have been infected with meningococcus or something else, and now have had amputations because they have impaired circulation to their extremities. Patients can have chronic organ dysfunction such as renal disease or liver disease. They can have cognitive impairment so that they're not as sharp as they had been prior to their infection, or they may be severely impaired as a consequence of the infection. They may also develop chronic debilitating muscle and joint pain, and they can also develop chronic fatigue. There are various screening tools that have been promoted for use by EMS. Everybody, or most, I think, are aware of the SIRS criteria, the Systemic Inflammatory Response Syndrome. And these are 4 criteria that have been promoted as being screening criteria for sepsis. They include fever greater than 100.4, or hypothermia with a temperature less than 96.8, a respiratory rate more than 20, a heart rate more than 90, or a white cell count over 12,000. We don't do white counts in the field, but it's been suggested, or a lot of the screening tools have been suggested for use in the field contain the SIRS criteria. But there's also been some studies out there that suggest the SIRS criteria, those things I just mentioned, really are not good predictors in the field. If you think about it, when you see a patient, if they're uncomfortable and they're sick enough they call 911, it's entirely possible their respiratory rate and heart rates could be elevated simply because of the adrenaline response to your presence. There are other screening tools out there that use components or additional components to the physical assessment that have been proposed as tools for use by EMS, but I think most of us would consider impractical for field use because they have 6 to 8 different criteria that have to be assessed. What we've decided to use was this pre-hospital screening tool promoted through a journal article early in 2016. It basically uses 3 of the 4 SIRS criteria plus end-tidal CO2. And that's what we're using now for our sepsis screening tool. So it's really based upon a clinical suspicion of infection, and I talked about some of those things that should prompt your concern, plus 2 of the 3 criteria listed, meaning a pulse rate more than 90, a respiratory rate more than 20, or a temperature greater than 100.4 or less than 96.8. Coupled with an end-tidal CO2 of less than or equal to 25. So basically, if the CO2 is less than 26. Why did we pick this one? Well, this was something that We work with COTS on developing, Dr. Kessig from Columbus Fire, the Regional Physician Advisory Board, um, some members of MEC EMS, as well as the Prehospital Committee from COTS, looked at this and selected this as a good place to start as a screening tool. If you look at it, it's got about a 90% sensitivity for septic shock, meaning it will identify 9 out of 10 patients who are septic. That's a pretty good percentage. Its negative predictive value is 93%, meaning that patients who have a negative screening tool based on those criteria, 93% of them are truly not septic, and only 7% of the patients who rule out by this tool are septic. All in all, it's not a bad tool for pre-hospital screening for sepsis. Plus, it's simple to do. So what do you do if your patient is septic? Well, it's what we've got in our protocol. So if you think the patient is septic, start them on IV fluids, give them a fluid bolus of 30 per kilo. If the patient remains hypotensive or does not respond to the fluids, start them on an epi drip based on the protocol, and request a sepsis alert by the hospital so that they're ready for you on your arrival. I realize some of our agencies have a short transport time, but if the patient is identified to be potentially septic based on our screening tool, our crews should start a fluid bolus and administer as much of that 30 per kilo bolus as they can prior to patient arrival. So that's my review for sepsis. I know you may be tired of me talking about it, but please keep this in mind whenever you see a sick patient, particularly in the elderly with altered level of consciousness.